Hello, everyone. My name is Ramin Tabatabai. For the next little while, we're going to be talking about gastroenterology, the GI tract. We're going to take a journey together from the esophagus all the way down to the bowels and out the bum, visiting a ton of different little organs along the way, and we'll talk about cases, pearls, clinically relevant things. So a few things to consider before we get started with this talk. Number one, we are not going to cover the entirety of GI. What I'm going to focus on in this talk is going to be highly clinically relevant pearls of diagnosis and management. We're going to talk about board relevant materials that you're going to probably see on the exam. And it's something to keep in mind. When things that you see in the clinical areas that are very common, on the board exam, they're going to not highlight the things that aren't as dangerous. You're going to get a disproportionate amount of patients with rare but life-threatening diagnoses. So if in your entire career you've seen one case of Boerhaave's or one case maybe of aortoenteric fistula, know that at ABEM General, you'll get 2 or 3 patients like that a shift. So every time you're going through the exam, consider these rare diagnoses. They're probably not going to be focusing on GERD or these lower acuity things. So why don't we get started with esophageal disorders. And we'll start with dysphagia. So starting from the top, the bolus of food goes in, and there's a couple different areas where things get stuck. So let's start with some semantics. Dysphagia refers to difficulty in swallowing, whereas odynophagia refers to pain in swallowing. So odynophagia, we think about certain conditions such as infected esophagus, esophagitis, maybe a foreign body that's sharp gets in there. But dysphagia generally has to do with either neurologic issues or mechanical issues. So as you're thinking about dysphagia, there's a couple places where it can get stuck. And whether you're in the clinical areas or you're reading about it on the boards, if somebody is getting food stuck on the initial swallow, right in the beginning, that tends to be more neuromuscular, something like a CVA or other neurologic conditions. Whereas if it starts to get stuck down lower in the esophagus, we start to think about more mechanical issues, malignancy, achalasia, eosinophilic esophagitis, those types of conditions. Dysphagia can also be progressive or it can be non-progressive. Progressive dysphagia tends to refer to something that is affecting the lumen or the size of the esophagus. As it progressively narrows, you will have more and more dysphagia. Whereas non-progressive or intermittent dysphagia can be a result of things like that are dependent on reflux. For example, eosinophilic esophagitis, where people can get reflux and start having issues with their esophagus, but it's not happening progressively, it just happens intermittently. Webs are another example of that, where you get these thin mucosal folds in your esophagus that are congenital. Sometimes they get stuck, sometimes they don't get stuck. So just a few things to consider there. In general, the workup for this is going to be, if it's not severe, outpatient, you can get them referred to GI, esophagram, endoscopy, some motility studies. But if it is severe and people can't tolerate solid liquids or it's rapidly progressive, generally those patients need to be admitted for endoscopy. So here are some interesting, maybe not your typical causes of dysphagia that come along with other associated signs and symptoms. So botulism, something that we see at our shop every once in a while. You'll get a bad batch of heroin or a bad batch of something that's being injected IV. We think about botulism in kids with honey, but in adults can get botulism as well. And if you have IV drug use with a non-clean needle, you can develop botulism, you can develop tetanus. So if they give you a question stem of a patient who's coming in with drooling, descending weakness, but also dysphagia, start to think about botulism. Under the immunologic, we have myasthenia gravis highlighted here. So if you get somebody who's coming in, a patient that has ptosis, they have some diplopia, and also they have dysphagia, start to think about myasthenia. And where would that dysphagia start? We talked about neurologic causes happening at the beginning of the swallowing process. So think about it when the dysphagia is early. And then finally, motor nerve dysfunction, achalasia. This is a denervation of the esophagus where you start to get some progressive symptoms. So some mechanical causes, non-neurologic causes, include malignancy, include any kind of tumor, thyroid masses that start to push on the esophagus. Zenker's diverticulum is something that, again, you may not see very commonly in the ED, but you may see it on your board exam. And so the clues to seeing somebody with Zenker diverticulum, this little outpouching that you get above the upper esophageal sphincter, is an elderly patient, generally men, who will start to come in with dysphagia, but they'll also give you clues like bad breath. They'll have halitosis. They may have regurgitation or aspiration pneumonia as a result of this. So start to think about Zenkers when you're given those additional clues. And then with complete obstructive sort of dysphagia, think about whether it's proximal or distal. If it's a really, really proximal obstruction, and we're talking about cafe corner, you're sitting there enjoying a nice dinner with your partner. All of a sudden, somebody at the table next to you starts to do this, and they're turning blue. That probably isn't an esophageal obstruction. That's probably something that's pushing on the airway. You see that, you're doing the Heimlich maneuver. Whereas something that's a little bit more distal and more likely to be an esophageal impaction, we are not doing the Heimlich maneuver on those patients. Those are patients that need to go to the hospital and generally get scoped. So the steakhouse syndrome that you hear about all the time. Somebody has some underlying pathology in their esophagus. They eat a piece of steak or chicken and they're not chewing enough. That thing gets stuck. Sometimes it'll go down, sometimes it won't go down. We're going to talk about esophageal food impactions in a moment, but that is a completely different workup and management than your patient that's choking. All right, let's talk a little bit about esophageal ruptures. When you think about esophageal rupture, like we mentioned in the beginning, at ABEM General, you will get many patients with esophageal rupture, whereas you're not going to see a lot of these patients probably in your day-to-day ED shifts. There's really 3 different ways that your esophageal can rupture. 2 of the ways are complete ruptures. One of them is an incomplete rupture. The most common way that people rupture their esophagus is iatrogenic. This is about 3/4 or 4/5 of the cases are now due to endoscopy, procedural. Somebody on the boards in real life gets a endoscopy and then comes in having symptoms of chest pain, drooling, maybe some palpable air. That is likely an iatrogenic, whereas the other type of complete rupture, which we're going to talk about in a second, is Boerhaave's from vomiting. The incomplete type of esophageal tear is a Mallory-Weiss tear. This is somebody who typically is drinking quite a bit with alcohol. They'll be vomiting, they'll be retching, and then they'll start to get a little bit of blood with their vomit. That is not a tear through the entire esophageal wall, but partial thickness, and these tend to resolve on their own. So you'd like to observe those patients, make sure the GI bleed isn't significant, something that's coming down from the stomach or varices or anything like that, but consider that. But the far more concerning types of esophageal rupture are the completes, the iatrogenics, and the oh-so-famous Boerhaave syndrome. This is a patient who will present with sudden onset, severe chest pain. It's in the differential for chest pain as we start to talk about in our cardiology section, thinking about aortic dissection, MI, and all those. Remember to consider Boerhaave syndrome. Sudden onset chest pain that is associated with what they will, the key to making this diagnosis is there's usually some sort of mediastinitis that leads to air in the chest wall. So if you, on your exam or in the question stem, there's free air along the neck, or a crunch, Hammond's crunch as they call it. Or on the chest x-ray, on the diagnostics, you see some air. That is very concerning for esophageal rupture. They may also have a pneumothorax. When they ask you about how to diagnose this, the gold standard is a CT, generally of the chest and abdomen, because you don't know where along that area that the esophageal rupture has happened. In fact, my only case that I remember of Boerhaave's, about 7-8 years ago, we had a gentleman who presented with severe sudden onset upper abdominal pain, not chest pain. And we ended up CTing him, and he ended up having an esophageal rupture, which we weren't expecting. But generally, it's a sudden onset chest pain. So the CT is the gold standard, but if somebody is unstable, they may need to go to the OR just based on the symptoms and the x-ray. If they ask you on the exam what type of contrast media that you want to put on your upper GI series, The wrong answer will be barium because it can be toxic to the chest, whereas gastrografin is water soluble. That would be the correct answer if they're giving you between those two. But generally, CT is the gold standard. And here are some of the findings that you'll find on the chest x-ray. Mediastinal layer, left pleural effusion. Let's take a look at this chest x-ray. On first glance, this chest x-ray doesn't look too terrible if you're focusing in on the lungs. So the lungs, you can see nice clear lungs bilaterally as you're going all the way down. You don't really see any pleural effusions or anything. But on this exam, when they're giving you chest pain, other than looking for wide mediastinum, other than looking for effusions, one of the places you really want to focus on is up near the neck and the soft tissues, where you'll start to see some tracking of air. That is the key to getting this diagnosis, clinching it on the exam. So if they give you Hammond's crunch, if they give you air on the chest x-ray, think Boerhaave syndrome. And in terms of management of Boerhaave syndrome, you're going to be thinking IV antibiotics, they need to go to surgery, and this is a major issue, major emergency. All right, let's talk a little bit about esophageal foreign bodies. So somebody swallows something and it can get stuck in different areas of the esophagus. In kids, one thing that's really important to know, so remember this, the cricopharyngeus muscle, C6, that is the most common area of narrowing and obstruction in children. Other common areas that you might be able to see, T4, T11, and some of the other ones that are listed here, are just important to know. Clinically not as relevant, but just know that for the exam. C6, pediatric, that's the highest level of narrowing. Now, one of the things that people can swallow, and usually kids, is a coin. And because the little kids have little esophaguses, and if they swallow a quarter that can be pretty big, or even a penny, that thing can get stuck. So when you see a kid, or there's a history of a kid taking a coin, you get the chest x-ray, you're going to get an AP, and you're going to get a lateral. Why do we need both? On the AP, it tells you what orientation the coin is, and that orientation ultimately determines whether or not the coin is in the esophagus or the trachea. And so if you think about the orientation of the esophagus, think about like a tube sock that's oriented this way, right? And the esophagus has a similar anatomy. So when a coin is ingested, the coin is going to be on face. So on the AP film, you're going to see it like this, on face. The trachea, on the other hand, has sort of a semicircular ring that's open in the back. And then, so if you get an AP film, the coin is naturally going to end up in this position. And so you're going to see just a sideways view. And a nice little mnemonic to remember how the coin is going to be oriented is SAFE, S-A-F-E, side airway, front esophagus, SAFE. And that holds for the AP film. So let's look at a couple of examples. Here's another slide on the areas of narrowing. So where is this coin? We're now looking at the lateral. But if we were going to look at it on the AP, this would be the orientation of the coin. You'd see it sort of sideways. You know that this is in the trachea. Whereas on the AP film now, you're seeing it on face. We know that it's in that esophageal structure. This is going to be in the esophagus. Now, with this image, take a look at this image. If somebody swallows a button battery, it's really, really important to distinguish between a coin and a button battery. Every time you see this image on the exam, take a few extra seconds to look for a concentric ring all the way around, sort of like a poker chip or a halo, they call it sometimes. If you see that halo or a concentric ring, that is not a coin, that's a button battery, and it's a completely different set of management, which we're going to talk about the different management styles for these. So if you have an esophageal foreign body, you're going to want to understand what type of imaging to get. So we talked about coins. They're pretty radio opaque. So an X-ray, a chest X-ray will be enough. However, there are other things that can get obstructed. Chicken bones, fish bones. Interestingly, different species of fish have different radio opacities. So certain species of fish you might be able to see on the X-ray, whereas other types of fish bones you may not see at all on the chest X-ray. And so then a CT scan would be the imaging of choice. Somebody swallows a toothpick, something that you think is sharp. You don't see it on the X-ray. The next best test would be the CT, especially if they're symptomatic. Now, most of these foreign bodies are going to pass on their own. They're going to get through the esophagus. They're going to go down the pylorus, and you're going to be home free. However, there's a few types of foreign bodies that we need to be extra mindful of. Some of those extra mindful types of foreign bodies are pointed objects. So if somebody swallows something sharp, that can get through the esophageal wall and cause a perforation. If it's wide, greater than 2.5 centimeters, if it's long, greater than 6 centimeters, those are objects that don't tend to easily pass through the pylorus. And obviously, we talked about button batteries. Those are all indications, if they're not passing through the pylorus, that we're going to need to get endoscopy and not just kind of wait for it. Now, I have a 3-year-old right now, and one of his favorite books, and actually my 7-year-old too, is There Was an Old Lady Who Swallowed a Fill in the Blank. And when I was a kid, I also thought this was kind of a fun book to read. There was an old lady. She swallowed a candle. She swallowed a cake. She swallowed the wrapping paper. And all these things were kind of interesting. Now I read that book to my children, and I think, wow, that just reminds me of the patient that we had yesterday who actually swallowed the candle, who actually swallowed the wrapping paper, and swallowed all kinds of things in between. So just be mindful. Try to get a sense of people. There are some psychiatric conditions where people will continue to swallow different things, and you may find things all up and down the GI tract. And if they're not radiopaque, you may need a CT to find them. All right. So here's an example of a sharp foreign body. If you see this photo, this is something that needs to be taken out because it can rupture right through the esophagus. This is probably not going to pass through the pylorus, and it's dangerous enough, especially if they're symptomatic, that you're going to be calling GI. Another object that we have to be mindful of are button batteries. Fairly common, oftentimes in kids. If it's in the esophagus, it needs to be removed right away. Why does it need to be removed? These button batteries, if they lay on the esophageal muscle, they will start to burn right through and can perforate your esophagus within 6 hours. If you YouTube esophageal button batteries, you will start to see all sorts of little experiments that folks are doing to show you just how dangerous these button batteries are. There are videos of a chicken breast and the button battery going right through it. There's videos of ham and bacon. There's videos of sausages. I mean, you'll find all sorts of stuff. But I would encourage you to watch that one of those videos to remind you just how dangerous this can be if you do happen to see that sort of double-ringed sign on the chest X-ray. On the lateral, if they only give you a lateral film, then look for sort of a little bit of a step off. You'll see a concentric ring and then a smaller ring that's stepped off right next to it. Those are all concerning signs. Lithium batteries are the worst of the worst. If they pass through the esophagus and the patient's asymptomatic, then you can get serial x-rays. However, if it's in the esophagus, we need to get it out to avoid any of these long-term complications, particularly for kids. There is a battery hotline, just for practical knowledge, that if you ever have any of these things happen, you can call the battery hotline and they'll help you go through any of this stuff. Just Google that. And in terms of home remedies, if you have a prolonged transport time, if this happens to a friend or a friend who has a child who may have swallowed a button battery, there is some emerging literature that honey and jam can temporarily help to stem the progression as the patient is getting to the hospital. So just some things to consider. There's some new evidence regarding that. All right, esophageal food impaction. This is a topic that's near and dear to my heart. Near and dear to my esophagus, I should say. I have this issue. I didn't know I had this issue. I like to scarf my food down fast. I grew up with a lot of friends, and it was feast or famine if you didn't get to your food and scarf it down quickly enough. So my MO in high school and college was to eat my food as fast as I possibly could. If I try to do that now, I will have food impaction every single day. I need to swallow my chicken 17 times. The reason is I have a condition called the eosinophilic esophagitis, and you should know about eosinophilic esophagitis. This is a common condition amongst especially younger people that can be associated with GERD. It's not always associated with GERD, but can be associated with allergic conditions, asthma. If you have somebody who has other allergies and they're starting to get food stuck, start to think about eosinophilic esophagitis. But of course, there are other pathologies, malignancies. We talked about achalasia, Schatzki's rings, all of those different types of things tend to exist. If you ever get somebody with an esophageal food impaction in the ED, and that food bolus passes, you're home free. Make sure you get them outpatient follow-up. They still need to get through, get their GI studies to ensure there's no underlying pathology, and the vast majority of patients will have underlying pathology. In fact, most will. However, if you get somebody who comes into your ED and they have the esophageal food impaction and it's not going down, there are a few options. There's a few options. The ultimate option, the true definitive management for this is a endoscopy and a removal of that food bolus. However, there are some intermediary steps that you can take. Number one, it is described that sometimes carbonated beverages can help. However, in the literature, in the reviews, there is no definitive evidence that carbonated beverages work, but some of that carbonation can help to kind of loosen up the smooth muscles and allow for passage of a food bolus. This is what I do at home when I have this. Unfortunately, I haven't, I've only needed to have an endoscopy one time, which was the first time that this happened. But carbonated beverages can help, but just know that it's not truly evidence-based. It's not truly something that is going to be the definitive answer on your exams. In fact, none of these options that you'll see on the slide are the definitive management. So glucagon, nifedipine, all help to relax the esophageal sphincter. However, again, the evidence isn't clear that any of these things are going to help. So if you get the way that I would think they might ask this on the exam, if they're going to add glucagon and nifedipine, maybe carbonated beverages, things of that nature, they might say, which of these should you not give? And the answer for which of these should you not give will be papain, meat tenderizers. We just talked about button batteries eroding right through the muscle wall of the esophagus. This was thought to be something that if we gave meat tenderizers to help tenderize the actual meat, the steak, the chicken, that might be something that would be useful. However, we have to also remember that the esophagus is a muscle. So it doesn't do you a whole lot of good to get through the steak or the chicken if it's also going to rupture your esophagus, which is what you're trying to avoid. So remember not to give the meat tenderizer.